Asia, and then knee surgery. He's performed over 1,400 hip arthroscopies and is very involved in the biologic aspect of translational and clinical care for his patients. He's lectured all over the world, from Las Vegas, Brazil, Copenhagen, Paris, South Korea, Taiwan, India, and has been recognized internationally for his contributions and commitment to sports medicine education and research. It's a great pleasure to have Dr. Uchida here. Thank you very much for joining us and making the trip to share your expertise.
It's my great honor to be here. I'm going to a little bit talk about the mesenchymal stem cell from human synovial tissues, where we are now. These are my disclosures. So first, I would like to express a sincere appreciation to Spry and Dr. Mark Philippon. He is my mentor on hip arthroscopy. I have a lot of about clinical knowledge and surgical techniques and everything. And also, I sent my fellows, Jimmy and Yoichi now, and working at the Spry to research with the Spry staff together. Thank you very much for taking care of my colleagues. So massive rotator cuff tears and also arthritis in the setting of arthritis of the patient is still challenging subset in the arthroscopic field, in the orthopedics field, because cartilage defect have a very limited interesting healing capacities and also progressive also arthritis. So treatment of currently in use for the cartilage repair is there are several strategies: is microfracture and mosaicplasty and autologous chondrocyte implantations. This procedure is covered by the Japanese insurance in our countries. But recent studies demonstrated there are no significant difference of clinical outcomes among these procedures. So my consider is stem cell therapy may be desirable strategies to treat a cartilage lesion. The mesenchymal stem cells is a good candidate for the stem cell research. The mesenchymal stem cell can be harvested from various kinds of tissues, such as bone marrow, synoviums, and periosteums, skeletal muscle, and adipose tissues, and trabecular bone, and umbilical cord blood. This is Dr. Sekiya's group, the Tokyo Medical Dental Universities, looking at a comparison of human stem cells derived from various mesenchymal tissues. What they perform is they harvest various kinds of tissue, bone marrow, synoviums, and periosteums, adipose tissues, and muscle during the ACL reconstruction surgeries. And then they compare the proliferative potential and the differentiation potential. They put the cells, the colony number of what they found is colony number of per 1,000 nucleus cells derived from the synoviums, the periosteum, the adipose tissue, and muscle was 100-fold higher than derived from the bone marrow. And the proliferation potential of the mesenchymal tissue derived cells. And also what they found the chondrogenic differentiation potential. The bone marrow and synovium and periosteum derived cells have greater chondrogenesis potential than do adipose tissue or muscle derived cell. You can see this graph is the chondrogenesis potential in the synovium is the best source of synovial tissue. Stem cell tissue. So I have been working on synovium mesenchymal stem cell with Professor Ishiro Sekiya, working at Tokyo Medical Dentist University. He's my mentor. This is Jimmy, and this is Professor Sekiya. So first, our research focus on massive rotator cuff tears. Massive rotator cuff tear is a challenging subset in the shoulder arthroscopy field. Also, arthroscopic rotator cuff repair has been widely used to obtain the good or excellent result. But a relatively high rate of tendon bone healing failure has been reported in association with inferior techniques as well as massive rotator cuff tears. So we perform the isolation and characterization of a human mesenchymal stem cell derived from shoulder tissues. We harvested different kinds of tissues, synovium, great humeral joint, and SAB versus the synovium. This is one of the synoviums, and the tendon of rotator cuff and essays of greater tendons. During the arthroscopic rotator cuff repair surgeries. And the culture at clonal density, one colony is formed by one mesenchymal stem cell, and the colony number means the number of the MSCs. This is clonal density cultures. Just one cell can grow the autonomous effect. With autonomous effect can make the colony. That means these cells is a mesenchymal cell self-renewal potential. And what we found is in vitro experimentally is the subacromial pulses derived from the cell have a greatest mesenchymal self-renewal potential. And also in adipogenesis and chondrogenesis and osteogenesis, SAB have a greatest differentiation potential. And the reason why we use the synovial MSCs is, you can see this graph is SAB is highest number of the colonies per 10,000 cells. That means 1.5% are MSCs. This means 400 times higher concentration compared to the bone marrow MSCs. So hip arthroscopic surgery has been evolving for the treating the femoral stubborn impingement in terms of surgical techniques and strategy in over 2 decades. Even though the application of the microfractures, a high rate of conversion of total hip arthroplasty and poor clinical outcomes after hip arthroscopy for FAI in the presence of osteoarthritis. That's why Dr. Mark Philippon and me are struggling with this in the setting of osteoarthritis. That's why Dr. Mark and me always train our bodies every conference.
John was observed anterior superior portion of the femoral head.
Treatment of the current issues for the cartilage repair consists of PRP, the microfracture, the mosaicoplasty.
The dilator was inserted into the drill bite and attached to the
This is an osteochondral autograft. This is a very limited indication.
From the hips.
So next, our research focus on isolation and characterization of the synovial mesenchymal stem cell derived from the hip joint. This is compared to the analysis with matched controlled knee groups. This minimum invasive stem cell therapy may be desirable strategy to treat cartilage lesion in the hip joint. And it is essential to evaluate proliferation of the differentiation potential of the MSC derived from hip joint for future application using MSC therapies in the hip joint. What we performed is we harvested 8 patients undergoing hip arthroscopy and knee arthroscopy in the same day. We harvested the knee and hip synovial tissue from the same individual. Okay, you can see the historical features. Knee synovium is yellowish. It didn't sink in the bottom in the PBS, but hip joint synovium looks like histological feature of the synovium is like the fibrous synoviums, but the knee synoviums looks like more fatty tissues. So what we found is the number of the colony is significantly higher in the knee joint synoviums than compared to the hip joint surrounding the labrum. And also MSC potential is a little bit higher in knee joint compared than hip joint. We concluded adipogenesis and osteogenesis is the potential of the MSC from the knee joint are superior to those MSC from the hip joint in the same donor. MSC derived from the knee synovium tissue may be better source of the future MSC therapies. But our question, we have hypothesized that the best source of MSC from hip joint should be the tissue next to the injury site. But what about fatty synovial tissue in the hip joint? Knee joint have a fatty tissue, but the hip joint have a more fatty synovial tissue we found. And then this study is Dr. Yoichi Murata is the first author to looking at synovium mesenchymal stem cell derived from the cochiloid fossa synovium have a higher self-renewal differentiation potential than those from paralabrum synovial tissues. This is published in the HSM. So we harvested different locations, the paralabrum and cochiloid fossa. You can see the synovium and cochiloid derived from cochiloid fossa have more fatty tissues. And you can see the colony number of the synovium tissue is a higher amount of the MSC compared to the paralabrum synovium tissues. And also in vitro differentiation potential is much higher in the cochiloid fossa compared to paralabrum synovium tissues. And also the synovium cochiloid fossa derived MSC had a higher multi-lineage potential than paralabrum synovium derived MSCs. We concluded MSC from cochiloid fossa synovium have a higher progression and differentiation potential than do those from the paralabrum synoviums and are therefore better sources. So clinical relevancy is synovium MSCs from the cochiloid fossa synovium patient with femoral stapler impingement syndromes are more robust in the vitro, suggesting the MSCs from this source may be strongly considered for the stem cell therapies. So they look back to the knee joint. Dr. Sekias attempted to clinically use of synovium MSC this is a case in the setting of chondral defect of the knee joint. And the synovium MSC is expanded with 10% autologous human serum for 14 days after digestion. And for transplantation, if the patient have an anterior aspect of chondral defect, anterior aspect of the medial femoral condyle, they elevate the knee joint like this and facing upward. The synovial MSC suspension was placed on the cartilage defect with the syringe and the arthroscopic controls. And then what they found is MRI scores improved from 1 point to 5 point post-operatively. And the Richter's scores before and after transplantation 76 plus minus 7 and 55 plus minus 3 is significantly improved. And also next step they try to clinically use for the synovial MSCs is degenerative meniscus tears. If you can see the developed meniscus tears, they fix degenerative meniscus tears, and then during the arthroscopic meniscus repair surgeries, they harvested the synoviums and also serum. Because the reason why they use their own serum, human serum, is some patients have allergy for the bovine serum. That's why they use the human serum. And then they put the cells, the culture them for 14 days, and they put back into the joint. During the arthroscopy, this is the repair site, and puts the suspension of the MSC just 1.5 ml. they speak Japanese, they spoke Japanese, exciting. And this is the before preoperative findings. They fix degenerative meniscus, and then synovial MSCs, and at 1 year after surgery, arthroscopic findings demonstrate to reveal shown as good healings. And also, Richardson scores improved preoperatively to postoperatively. And this first human study confirms the combination of surgical repair and synovial MSC transplantation improves the clinical symptoms in the patient with complex degenerative tear of the medial meniscus. In conclusion, synovial MSC is one of the best sources of stem cells therapies. In addition to fatty synovial tissues such as SAB or cartilage fossa have a greater MSC potential than fibrous synovial tissues. Combination of arthroscopic repair and synovial MSC's transplantation can be useful for cartilage damage and fiber cartilage injury such as meniscus injury in other joints such as hip joint. Thank you very much for your attention.
Dr. Uchida, thank you very much. Very impressive work. I'd like to introduce Dr. Scott Tajman, who's a great friend of many of ours here, and